Welcome to the Regional Health Solutions podcast, powered by STATIM.
We're your hosts, William Mundt and Jaden Frame. Welcome back, listeners. So we're on to episode 6 right now, and we've been doing these podcasts for 2 years, and we've had some fantastic conversations with a number of different people, and bringing it all together to see where we're at as of 2026. As you know, there's been a Toowoomba Regional Health Industry environmental scan and a workforce development plan developed. Workforce is at the heart of what STATIM believes in the sustainability of health in regional and rural Australia. So we've dissected the current workforce plan, which was completed by TSBE and RMEA. It's a fantastic document, and we've had lucky enough to have Marilyn Strofeld, the author, come and join us on the podcast. But we're looking at what that looks like and what are the real actions out of this report, what can people be doing, and how can we improve the sustainability of health in regional and rural Australia by growing the workforce, and what are the challenges, what are the real challenges out there that people are sitting on and trying to address, and understanding the industry has its complexities. And I've said this a number of times on the previous podcast, that it's a huge industry. It's the largest employer in our region at 13.5 or now 15,000 FTE. It's 50% dominated by Queensland Health, and there's a Toowoomba hospital getting built, so that concentration risk is increasing, and the responsibility of one entity to carry the burden of workforce development is significant. However, then you look at your hospitals and your private hospitals and your aged care, and then you step back to this small business mentality with your GPs and allied health in the region, and have they got the capability and capacity to grow workforce in our region? And the answer is no. So that there's some complexities in this workforce development plan, and it takes everyone to lift and collaborate. So all the ships in a rising tide do rise, but who is taking the lead on this? Who is driving it, and how do we do it? I want to welcome my business partner, William Mundt, to the STATIM.
Yeah, thanks, mate. Look, one of the things I keep coming back to when I read that environmental scan and then onto the workforce development plan that Marilyn developed was we tend to default really quickly to talking about workforce shortages. And it's not wrong. There's certainly workforce shortages, and everybody in healthcare can probably attest to that. But I don't know if workforce shortage is actually the most interesting thing in the report. And what I think the report really points towards is this workforce development capacity problem. And on page 30 of the report of the workforce development plan document, so that's the second half of the study that they did, they talk about this grow your own approach. Now, grow your own gets thrown around in the industry quite a bit, but they basically dissect it down into two elements, which is this outside-in strategy and then this inside-up strategy. So when you look across the region, we've got people invested in healthcare. We've got students, we've got graduates, we've got facilities carrying these vacancies, we've got communities that actually need the care. Somehow these things aren't connecting as effectively as they should. And what we're hearing from providers isn't, we don't want students, we don't want graduates, we don't want to develop people. What we're actually hearing is we don't have the time, we don't have the horsepower or the educator, or we don't have the supervision capacity or the structure to actually make that happen. And I think that that's actually an important distinction, which is the industry isn't short of goodwill, it's short of capacity. So the challenge that I'm seeing isn't simply attracting people into healthcare. That's definitely part of it, and the report addresses that. But what I love about the report is that it addresses the other half, which is the challenge is actually creating the support structures around them once they get there.
Which is true. When you start going back to my original point of the liability of workforce development largely lays with Queensland Health because they're the largest player. But again, and the conversations we've had with stakeholders in that training space is it's very hard to identify training spots and clinical facilitators to help train the next generation because the liability is with one organisation.
Yes, it is. However, I think this is ubiquitous across all the facilities and organisations, is that the exacerbation is when there is a workforce shortage or when budgets are constrained, the first roles we know that are pulled are facilitators or mentors or educators. So it's this cascading problem where we have people in the industry, but you have to deliver the care. So how do you balance educating and maintaining your workforce competently, but delivering the care when you're in? And that's where I come back to. Like, it is a workforce shortage. I'm not neglecting that, but the report goes a little bit deeper and says we've got this development capacity shortage.
And that's, we agree with that full-heartedly, and why we've gone down this path of investing in things like clinical facilitators and programs to upskill the RNs and connect students to industry to fill that gap of that, which is a market-driven force that you've just said there's a gap there, and STATIM is a solution company, so we've filled that void, or in the process of filling that void around the clinical facilitators, which the uptake of the RN upskilling program across the state has been rapid in the last. It's a new product, but in the last month or two, it'd be interesting to see where it is in 2 years' time.
Yeah, the RN upskilling program certainly scratches an itch that is there, and I think if you go a level deeper, it's a symptom of the industry at the moment, is that we've hamstrung and painted ourselves into a corner where we've built graduate entry into the workforce on grad programs as the only entry point into the workforce. So healthcare, and I'm just thinking from a hospital lens only in this instance, that we become increasingly reliant on grad programs as the only pathway into practice. So grad programs are fantastic and they have their place. So the challenge, I suppose, is when they become the only recognised pathway that new grads, whether RNs or ENs, can actually find a leg up into a facility. Healthcare is much bigger than organisations that run grad programs. We know that, and you touched on that before. 60% is Queensland Health. The smaller facilities tend to not run grad programs, but they all have a hand on the wheel somehow to make sure that they're contributing to this workforce plan. So, and I can tell you anecdotally, we've had multiple graduates who have approached us looking for work, which this style of work is really hard to achieve and do successfully. As a graduate, you do have to have some level of experience to be able to manage the fragmentation of the style of work that STATIM offers. And on the other hand, we've had facilities who approach us looking for staff. So somehow the two still don't connect, because the graduate program then becomes the default of entry, where I personally have reached out on a number of occasions to contacts and colleagues that I have to introduce graduate nurses. However, again, the response seems pretty similar across the industry, which is they're unwilling to take these guys outside of grad programs, which, back to my first point as we started talking, is it is a workforce shortage, but it's this workforce development problem that we have. So, you can have graduates that are fully qualified, they're fully registered, they're ready to contribute to the workforce, but the answer is, we'll see you at the next intake, or we don't have the grad program, or we don't have a structure to support someone new. So I think we've accidentally created this bottleneck where workforce doesn't operate on these annual intake cycles. The facility is short now, the graduate is available now, and the challenge is really around how we support them now.
And it probably defaults to and it's something I've talked to in the previous podcast, Jeff Argus, the one employer model. How do you give capacity to an industry that is reliant upon one person to grow the workforce, or one entity? And that one employer model where, and this is where I believe there's an opportunity for our relationships and our agreements at STATIM, that we work across multiple facilities, and with the right mentoring and the clinical facilitation, which we have, growing that, giving that person that experience in a regional town, be it Warwick, be it Chinchilla, be it Tara, where we can actually place someone across public, private and NGOs when they're anchored to a region, and ideally, and this is one of the points they make in the workforce development plan on page 36, the regional collaboration and sharing data, understanding where people come from when they do their training, so then they can go back to that town and practice as an early practitioner. It actually removes that need of finding a house. If you're going back to for the region you're living to do your first job after you've graduated, but that data doesn't exist. To try and grab that data and go, well, someone grew up in Chinchilla, they've just finished at Uni SQ or UQ or Southern Queensland Rural Health, and a grad position, as you're saying, Will, in Chinchilla comes up, they give it to one person, and that person might be from Brisbane, might be from Townsville, might be from WA. And if that person from Chinchilla misses out in that grad program, where do they go? They move away from the region. And that data sharing is so important. And it's one of the true barriers that we've found at STATIM, that, yes, at universities there's privacy concerns and you can't share that data, I get that. But how do we work collaboratively to actually find people in region that train in region to then practice in region? And the research is there that shows that it's more likely that happens. But I believe that if that's more coordinated and that data is shared, those stats will escalate quickly and solve potentially one of our challenges around local workforce.
Yeah, and drawing all of those loose ends and thoughts, I suppose, together, they're all interrelated. You've got a larger organisation that offers grad programs, so they're generally advertised ahead of time, and the graduating workforce know where those opportunities exist. However, there's a number of smaller providers that when the vacancy comes up, the vacancy is up. They don't have time to wait for a mid-year or a beginning of the year intake. So we've got this alignment problem between availability of positions and the availability of staff. It's this supply-demand mismatch. And overlaid with what I was saying before, the ability to support our clinicians in ways that are different to traditional grad programs. So this is how we end up with the Gundawindi local, training local, potentially even doing their clinical placements locally, but ending up in a metro area somehow because the position did not align to their availability at the time. So, couple that with the transparency of postcodes of graduating clinicians, couple that with workforce development plans of organisations that sit in a local area. These are problems to be solved where if we get it right, we can coordinate it in a way that scratches nearly every itch. And further to that, which isn't the sales pitch at all, but it is the reason why at STATIM we're trying to broadly think of how you can solve for this. And it starts even beyond workforce infrastructure is before they're even graduated. It's back to when they're at high school and connecting them to industry and connecting them locally. The micro-credentialing program is the perfect example of that.
And the micro-credentialing program, and a shout-out to the federal government, which has provided the funding, the local jobs, local people, has funded STATIM to run this program over the next 12 months. And what it is working with school students or youth and connecting them to industry. We're putting them through 44 micro-credentialing units over a 8-week program, and it connects them to industry. It gives them, they're inducted to the facility. They have direct supervision from a clinical facilitator, and they're guaranteed a job at the outcome when they're completed. So it's a soft entry to industry. It works for the health industry. It works for the individual. It works for the school. It's a win-win-win. We ran a pilot last year, and the outcomes are phenomenal. And grabbing those kids now, we're putting 45 through over the next 12 months from school to industry with guided support. These kids that are sitting in these chairs now at school are the kids that will be walking into our new hospital in 2028.
Well, they've got their certificate. They've already made the decision that healthcare is their journey. The challenge is that there's this vacuum between them finishing in grade 11 and actually starting tertiary studies, whether EN or RN, and you risk losing them to another industry, which is why the micro-credentialing program came into existence. Was we recognise that, much to the theme of this discussion, is that those vacancies exist now, and you've got a workforce that is available now, but there's no bridge gap between finishing the cert and connecting to industry. So we're not replicating anything that's happened that they've achieved in the certificate. These are micro-credentials which are actually more focused on soft skills, like how do they hold themselves in interview? How do you develop a CV? How do you be resilient? How do you debrief and do clinical supervision effectively so that you can be the best clinician and show up for residents or patients? So, and couple that with what we were talking about before, which is growing local workforce. Those students often, or do, belong to a regional community, whether it's Toowoomba or Gundy or Chinchilla or wherever. They've got family there, they build a community there, they do sport there, they identify themselves as locals, and connecting them back to their local healthcare industry locally means that you're more likely to keep them there. So, in my opinion, if we're the second or third or fourth industry to react and engage students, given the rate that health and aged care is growing, we will lose. So the early answer is the exposure and the connection to industry. The second half of that is the training and the placement and the facilitation and the mentorship, which is the challenge we outlined earlier in the episode. Was, yes, we would love to connect them to the industry, but then the second half of the challenge is, well, we're in this deficit, how do we support them? Which again is where the program comes into its own, and they get the one-on-one mentorship. They're orientated and facilitated to the host facilities, processes, policies, people's culture. So at the end of it, you've got a strong clinician who's connected locally to the community, who's connected to the facility in a fully funded program that solves the workforce pressure that they're facing.
It's a win-win-win for all stakeholders. Now, Will, the RN upskilling program that is being rolled out at the moment, can you give the listeners an overview and have a bit of a rabbit about that?
Well, the RN upskilling program is just an extension of everything that we've just been talking about. Most of the listeners will likely have had teams that they've managed and led. We've all sent our teams away onto training or symposiums or seminars for a couple of days. They come back, they got a bit of fire in their belly. They're likely to put some change into place, but we all know that within often a few weeks they default and fall back into the same habits. Change becomes fatiguing. They don't have the ongoing support of what they learnt at that education. So where we developed this program was off the need of recognising, again, everything that we've been talking about up until now, which is this leadership crisis that exists in the industry and this shortage of ability to mentor and ongoingly facilitate people in their roles and show them the core fundamentals of how to actually do their role. So we recognise that, yes, you have to have some theory component behind it, so we couldn't neglect that, yep, we've got to sit down for a few days and actually go through some standards and fundamentals of how you perform your role. But it's a 12-month program where the first 3 days sets up the platform to then go on to have ongoing mentorship, where these guys have a clinical mentor and an ongoing sponsor with someone who checks in with them regularly and helps them make decisions live in their work environment.
Well, and this RN upskilling, Will, it's again a demand supply need that industry approached STATIM and said, we have an issue, and we heard the jungle drums beating from numerous facilities saying, hey, I want to upskill this nurse. I don't want to send them away. I don't want them to do additional study, and I need it to be practical. But the issue is they haven't got clinical facilitators that can actually take time out of their day to drive these programs.
Well, and it's also assuming that every RN, and it's targeted at RNs for now, the hope is to grow this platform to be more than the RN cohort, but for now, it's assuming that every RN has the same learning agility and is starting from the same level of knowledge and skill set, which we know isn't the case. So as leaders and managers of teams, we all know that feeling when you go, right, the team has X deficit. However, it's on a different scale depending on which clinician you talk to. And so generally, the only tool at our disposal is to send people away to training, whether it's a symposium or a seminar or wherever you send them to, and they all get the same level of training. It's not bespoke, and it's not...
If they get training, Will, and that's the question. I mean, the old saying of what happens if you train them and they leave, or versus what happens if you don't train them and they stay. The capacity of training, even in the regions, is challenged.
Well, and anchoring it back to this workforce plan, inside up strategies. So training and upskilling, which leads to career progression opportunities, are all interrelated. So if they feel valued and they feel like they're getting invested in, they're more likely to stay. So I think that argument becomes a moot point. What's the alternative? You don't educate and you don't upskill for fear that someone's going to leave. Well, if you don't educate and you don't upskill, they're going to leave. So I would rather have an invested and upskilled staff that are more likely to be engaged and stay than an uneducated and unupskilled staff, if that's a word, who are going to leave anyway. So all that to say, the RN upskilling program, like the micro-credentialing program, was born out of a need that we saw and were approached by a facility who said, hey, we recognise we've got a leadership crisis, we recognise we've got an education deficit, but we want to solve this in a way that is different than just blindly sending people to education sessions. We know what that looks like. We assume they have the same level of understanding. We assume they have the same learning agility. We send them to the same education course. They come back with a bit of fire in their belly. They try to change or implement change or a project. And without ongoing mentorship and support, I can attest to this. They lose the fire in the belly. They default back to the same behaviours, and they might be slightly upskilled having gone to the education session. However, there's no meaningful change that comes out of it. So what is the RN upskilling program? We developed it as a 12-month program, which is an ongoing mentorship with a dedicated clinical facilitator that checks in with that RN on regular intervals to make sure that they're on track on the program. There is a component at the front end that we deliberately build theoretical components with the facility and the senior leadership team to make sure that there are core and adjunctive modules that we address. So if there's a theme of courageous conversations needing to take place, or there's a theme of SIRS or SAC1 events, say falls or wounds, we make sure that that's in the theory component. We set these guys up with a really strong foundation on the fundamentals of nursing. So whether that's the standards of practice, both nursing and whether NSQHS or ACQSC standards, we set them up with the baseline skill sets to be able to do things that we expect them to be able to do now. Nursing is no longer just delivering patient or resident care. There's a whole heap of things that we now expect in a scope of practice, like being able to delegate effectively, being able to run a emergency management plan effectively after hours when the fire alarm goes off. And we expect them to be able to run a budget. We expect them to be able to manage staffing appropriately. So all of these things are baked into that theory that we front load the program with, and then we individually sit down with the participants and set goals and strategies for things that they will work on over the next 12 months. Generally, they anchor that to a quality improvement initiative that they have to deliver, and our clinical mentor, our clinical facilitator, is allocated to these guys to do regular check-ins, make sure they're on track, ensure that we can nudge left or right depending on what they're working on. They have full access to our mentors, so they can ring them at any time to make sure that, you know, if they're stuck at a crossroads and they need to know to jump left or right, they can ring and debrief that over the phone. We meet with the site leadership team and make sure that the whole program is effective and on track. We meet with the organisational leadership team so that any initiatives that are coming out of the program are cascaded up to continuous improvement plans for the whole facility. So although there's a increase in the competency and confidence of the individual clinician, the whole organisation as a whole is benefiting. And I won't call out specific organisations we've done this with. However, one example where we put 7 participants through saw a $180,000 increase in ANAC funding per annum, simply by better documentation practices that the participants were able to put in place. Not that it's about money, it's definitely about resident and patient care and the confidence of the clinician. However,
it certainly helps if you've got more money to pay the bills. Well, I won't complain.
The point being that it pays itself off. Yeah, it definitely didn't cost $180,000 to run for 7 participants.
Yeah, a win-win-win. And they're 2 examples of market-driven products that STATIM has developed over the last 12, 18 months. But going back to this workforce plan, and we've talked about numerous things. We live in an ecosystem in regional rural Australia, because the ecosystem, you know, certainly you can't just go robbing from Peter to pay Paul. So you got a new hospital. What's your plan? Well, we take it from private industry. Well, where does private get these? So it's understanding we're doing our part to fill gaps, but it is a collaboration, and you need to be working across industry in the regions to get outcomes. And I'm going to call the industry out at the moment that we've got a roadmap here that's been developed, and it's a good roadmap. Not surprising, some of the things that are in there, but what are we doing? Like, we have seen this come out 6 months ago. It's a roadmap of what needs to happen, And we need leadership. I've heard that said a couple of times. We need leadership to drive this forward. But why isn't anyone driving it forward in our region? And again, not at all pointing at the largest employer of workforce, because it's not their responsibility to own 50% of the industry and grow 100% of the workforce. So how do we do it? Well, how do we grow this industry, or how do we create this ecosystem and drive this leadership? Or how aren't we doing it at the moment? What are the barriers? What are the blocks? Why aren't we doing it? And look, the first thing that comes to my mind, and again, this is a not-for-profit mindset, someone's looking for funding for the next stage. And when you're looking for funding for the next stage, the government is paying for the next stage. Why can't, as an industry, there's so many commercial benefits to what we're doing. Why can't we pull this together? And this is where I'm happy to stick a hand up at STATIM and go, well, we'll lead this thing. We'll drive this. We have the relationships with most facilities in the region, if not all the facilities providing workforce solutions and technology and advisory and infrastructure solutions. So why isn't this initiative getting pushed forward right now? It goes back to the episode we had with Graham Russell and the default of change within the health industry. We don't like change, and we always, it comes back to the capacity thing. And how do you embrace change, and how do you do change management? And it's something the industry doesn't do well because they haven't got capacity. And exactly what we've talked about with the R and upskilling, they go back, they default to the biggest risk or the biggest emergency, and things get missed.
Mate, why isn't this being solved? You've asked me to solve the unsolvable here potentially. There's probably two ways in my head that I'm thinking of this, and that's, you've got a long-term solution, which is we know that the future of healthcare cannot continuously look how it is at the moment. So I think we're in a period where we're going to have to start redefining what health actually means. And it's a tough question because you think of our current system, it's very good at responding to illness. It's very reactive. And I think what we're going to have to lean towards is a model that's more interested in helping people stay well, because we can't maintain the reactivity in the current system. And what that means, as we know, is helping people stay connected, stay independent, stay engaged, stay part of their community. And if anyone's read the book Blue Zones by Dan Buettner, it challenges some of our assumptions, I think, about what actually creates health. So in Blue Zones, just quickly to summarise, the communities where people live longer and healthier and have longevity but are happier where they are, it's not what most people expect. You don't have more hospitals in those areas, you don't have more specialists, you don't have more treatment. It actually comes down to them having connection and purpose and belonging and a community and these relationships that are intergenerational. And this is a worldwide study. So strong social networks and staying connected as they age. And it challenges our assumptions because we've accidentally actually built an illness system rather than a health system. And we become exceptionally good at responding to illness. But as I said, the reactivity of if somebody has a stroke, we want that system. If they have a heart attack, we want that system. If you've got cancer, you want that system. And its capability at the moment is extraordinary. It's straining under the workload, but it's working. But what we're less good at is supporting people before they actually reach that threshold. So helping them stay engaged and mobile and creating these blue zones that the book talks about. What's the reason for that? I think we have this fragmented care continuum. So, and I'm answering your question in a more long-term way, which is the whole health system needs to be looked at. We've got primary care, we've got allied health, we've got hospitals, we've got aged care, we've got NDIS, we've got community care. They all have different funding streams. They've all got different reporting structures. They've got different governments that they're funded by. But the person themselves doesn't experience healthcare that way. It's one life that they are on the journey of their healthcare continuum. They don't say, well, I'm a Medicare patient at 10 a.m. and I'm at 12 p.m. I become an allied health client, and then I'm a aged care consumer at 5 p.m. They're trying to live their life, live it well, but they're having to navigate this friction in the system. So I know that's a pretty utopic answer to your question, but it's the long-term answer, is that we've got all these streams. So from a system perspective, they're all separate. From the person's perspective, it's one life. And the funding's fragmented, the person isn't. And people fall through those gaps, I think, and that's where the current model can sometimes feel a bit like a conveyor belt. So the long-term answer, I think, is that the health system itself will need to become more congealed and obvious where the person accesses this. The shorter-term answer is why or how can we execute this strategic plan? Who steps up? Who's the person that's ultimately responsible for it? Look at the system currently. We've got fragmented strategic plans. Every organisation would have their own strategic plan. Every organisation would have, zoom in on that and double click, they would have their own workforce development plan and strategy. Private providers have to make money. You have to make a profit. Government providers, they also have to make money. They work in budgets, but they're also expected to care for our most disadvantaged and underprivileged of the community in a model which makes it very difficult to work within a budget. So you said before, when they own 60% of the industry, a lot of the burden does fall to the biggest provider to solve the problem. And call it out. Is this Queensland Health's responsibility to look at the workforce development plan for the whole industry? Of course it isn't, but they own 60% of the industry. So small guys who do not have the capability to do it look to them to say, all right, we're going to rely on whatever campaign you're going to run to bring people to the region, and hopefully I can ride on the tailcoats of that to attract people to my facility.
Well, and if it's not Queensland Health, and if they haven't got the capability or capacity, they definitely have the capability, but do they have the capacity? Is it in our region, St Vincent's and St Andrews? Well, no, it wouldn't be, because it's the same problem. So then you default down to a facilitator, which TSBE would be a great facilitator in that space. But I suppose they're looking for funding to get it driven. Who else is available? And is it up to private industry, e.g. STATIM, to put their hand up and say, well, we'll drive it and we won't get funding?
Which is my answer. My long-term solution is we have to redesign the way health and aged care is delivered. We are in a reactive model that creates way more burden at the back end of life than if we had a social and connectivity structure. And I'll call it out on here. Anyone who wants to Google a Bernie Bray model is exactly aligned to what I'm talking about in regards to the blue zone mentality. Now, that's utopic, and that's going to take decades, potentially, to get to. The short-term answer is we all have to align our strategies and strategic plans, which has already been done. That is what this document is. It's a workforce development plan. It spells it out.
For the region.
For this region, but it's imminently replicatable.
Correct.
With the right data. Like, you would still have to go back and do an environmental scan on each area and make sure it is replicable. But globally, things like the outside in and then the inside up strategies don't go away simply because we're then talking about Bendigo or any other regional town. It would be these are ubiquitous problems. And I think that there is a ubiquitous solution, which is it's not any one individual's responsibility, but it's everyone's responsibility. And the only way I can see an alignment of strategy is a convener. You have to have a convener.
Specialised convener. So, with that, we'll start to wrap up the conversation. And look, if anyone wants to reach out and have these conversations, STATIM is a solution-based company. We look at market-driven forces and try and add value. If you spend $1, you get $2 back is how we like to look at things in the health industry. And I certainly believe a coordinated approach to this industry will be to everyone's benefit. So if you do want to reach out to us, feel free to go to www.statim.com.au or contact Will and Jaden directly on LinkedIn. We are looking at solutions, and we want to be part of the solution, not part of the problem. Thank you, listeners, and
echo those sentiments. Thank you, everyone, for listening. It's a provocative topic potentially, and one thing I've always realised is that there are people who can sit and talk about a problem and define a problem, And then there are people who can actually get in and start solving the problem. And I'm more interested in working with people who are the latter. Where STATIM is interested is as Jaden said, we're trying to innovate, try different things, and not recycle the same solutions to the same recycled problems. We want to look for ways to do things differently, and that's the reason that our first value is strong relationships, is to continuously partner with people who are brave and want to try a different approach to these things, which, as I said, this document clearly outlines a well-defined path and a solution to the challenges that we're facing. So we'd welcome any feedback and connection to be able to make that happen.
My favourite phone calls are the ones when people call and say, hey, Jaden, have you ever thought about doing this? And then we go and do it.
Yeah, give us a ring and ask us about doing something.
Roger.
Stay connected with the conversation about enhancing livability through sustainable healthcare solutions for regional Australia. Visit statim.com.au/podcast to learn more, connect with us and join the movement towards a healthier future for our regional communities.